Hello and welcome to the Cancer Education Series, brought to you by MercyOne and Above and Beyond Cancer. We benefit from a grant that we received from the Iowa Cancer Consortium, and we're very grateful for that. My name is Chris Gooddale, and I'm the Executive Director of Above and Beyond Cancer, and it is my weekly pleasure to introduce the founder of our organization, Dr. Richard Deming, who will introduce our speaker for this evening. Dr. Deming?
Great. Thanks, Chris. Welcome, everyone. You're in for an informational and educational and inspirational evening. We have two cancer survivors. They're going to tell their stories, but also give the example of what it means to pay it forward. Through my career as a cancer doctor, I've seen time and time again as cancer patients go through their own journey, they come out with this sense of wanting to help someone else. And today is a great example of that. Two breast cancer survivors who are going to talk to you about breast density, what it is and why it matters, and how they took action into their own hands and helped pass a bill at the state legislature that they'll talk to you about in terms of making sure that every woman knows what their breast density is. Our two speakers tonight, first of all, Brigid Greening. Brigid is from Michigan originally. She went to Notre Dame and she worked in the pharmaceutical industry. And then she had 4 children and became a mom and was diagnosed with breast cancer. And she's going to tell you her story and how she got active in advocacy. And second, Dr. Jean Paul. Dr. Paul grew up in Urbandale. She became a nurse first and then got a master's of nursing from Drake and went to DMU and became a physician and then a family practice physician. So she speaks tonight not only as a cancer survivor, but as a physician and the role of being both a doctor and a cancer survivor. And they're going to talk about breast density and about advocacy and how we can make a difference helping to reduce the burden of cancer. So I'm going to turn it over to Dr. Paul and Brigid.
Well, thank you. We're really honored to be included in this series. I know it reaches a lot of people, and we're just very honored to be here. I'm going to let Brigid start off because she was actually there at the start. I didn't get involved until a little bit later in the story, so I'll let Brigid start.
Well, my story begins back in 2016. I don't know if we want to stop shit. Right,
I don't know. We're not really good at this. You just do stuff. But.
So in 2016, I had been followed by mammography every 6 months, and because they were following some calcifications, the radiologist said, okay, we'll come back in a year. Everything looks very stable. And then about 8 months later, I found my tumor on my left side, and immediately went into treatment, started chemo right away, but met with my surgeon and I said, so, tell me about what I'm facing. And he said, well, this has probably been growing in you for 18 months. And I said, well, I had 3 mammograms during that 18 months. And he said, well, you have dense tissue, and that makes it more difficult to find cancer. And at the time, I just kind of said, okay, well, that tells me why, but I need to look forward. And I just went into treatment straight away. Started chemo in October of that year. And about Christmas time, I met Brigid Pargowski, who is another breast cancer survivor. And she mentioned going back down after the first of the year in January of 2017 to lobby for a notification law for breast density. Most times in the past, the radiologist would inform the primary care physician about the density after reading a mammogram, but the patients weren't aware of their own breast density. They would just receive the letter that would say, no evidence, or everything looks clear, come back in a year. that type of thing. So bald as a cue ball, I went down and began lobbying with Brigid and also Dr. Robert Schreck, who is a retired oncologist now. And we went and kept presenting our information. This was not the first year, and it was actually about the 7th year that Brigid and Dr. Schreck had been down at the State House. And that year it passed. So in April of 2017, Governor Branstad signed the bill into law. And then in January of 2018, it went into effect. And since then, every woman in Iowa has been notified of her breast density. So.
And then in 2017 as well, I knew Brigid from church. And I found out in October, I had gone in for my routine mammogram. It was a very rainy day, October the 10th, 2017. I was one of the first ones there. It was like 8 o'clock in the morning. And I went in for my routine mammogram, and per usual, I had a list of my long of things I needed to get done on my day off. And they said, Doctor, the radiologist would like to speak with you. And I said, I suppose they're going to do an ultrasound on that right breast again. So I went walking into the reading room, and the reading room is dark, and there's like x-rays all over, and it's quite intimidating for anyone. And I, of course, was not there as a doctor. I was there as a patient, and the screen looked to be about the size of the whole wall. And I looked and I said, well, that's not my mammogram. And she said, yeah, yes, doctor, it is. And I said, I have breast cancer and it's already metastasized. And she said, yes, doctor, it has. What time did you want your biopsy? So that's how my day started. So within a 3-hour period, I had my mammogram, my diagnostic ultrasound, followed by a core needle biopsy. And from there, it catapulted into meeting after meeting after meeting with, you know, the oncologist and with the surgeon and the radiation oncologists. And I just knew that I had metastatic breast cancer. And I was pretty good at getting my mammograms, but I might have been a few months late. Like a lot of women, you know, it's normal, you file it, you don't really think about it. So I was going through chemotherapy, and Brigid Pargolski walked up to me in church one day, and she said, would you like to join the Iowa Army of Pink? And I just said, sure. And she goes, you don't know what it involves. And I said, I don't care what it involves. If it means that I'm going to be able to help other women, then I'm all in. So that is how I became involved. I ended up being stage 2B, triple positive. So I elected to have a bilateral mastectomy. For those of you who are unaware, the HER-positive breast cancer tends to be a little bit more aggressive. I'm feeling better now in 2021 than I probably would have 10 or 15 years ago. The life expectancy of HER2 cancer at one point was 24 months. And here I am 3 years later doing well. So that being said, I joined the troops, and once the law was passed, our goal now is to educate women and to educate ourselves right out of a job. So many women know that they get their mammograms, they get their report, and they say it's normal, and they throw it out. They have no idea what their breast density is, even though it's been a state law for 3 years. And if they do know, they don't really know what that means. So our job as the Iowa Army of Pink is to now make sure that women are aware of what's going on. I think Brigid pretty much covered our first slide here. The federal law now states that the patient as well as the doctor gets the information. We're trying to figure out how to forward the slide.
Oh, there
okay,
we go. Just click it.
Yeah, in 2019, it also became a federal law that women are made aware of their breast density, but it's still at a state level, state by state, determining which women. So some states might mandate that all women get it, like Iowa. We're very progressive. We're very proud of that. Some states only notify women if, in fact, they have dense breasts, which we'll get into that in a little bit. One of the first questions people ask is, what is breast density? They'll say, I'm fat, I'm flat, I don't have any breasts. But it's not something that can be diagnosed on a physical exam. It is strictly a mammography finding. Women who have never had a mammography do not know what their breast density is. So it is the ratio of the fibroglandular tissue related to the amount of fat. I remember going for my first mammogram, I think I was 35, and they said, oh, you must drink a lot of coffee because you've got very fibrocystic breasts. And I said, yeah, I'm a medical student. I'm not gonna not drink my coffee. And I didn't think anything of it because no one told me that it put me at an increased risk for breast cancer. It is a gradient. There are 4 levels of density currently that we are recognizing. That may change in the future as the mammograms and the software become more sophisticated. Increased density is lifelong. For the most part, it doesn't change. It can decline after menopause, but my caveat I tell women is that if you're dense, you're dense. And just be aware that it may be a gradual trend, but you kind of are what you are. And so far, we have no way of reliably decreasing that density. It's what you're born with.
So here are the, here are images of the 4 different categories. The percentages across the top are the percentages of women. So you can see the left half, categories A and B, comprise 50%, and the right half, categories C and D, also comprise 50%. The heterogeneous, category C, and extremely dense, category D, are what is considered dense tissue. So you can see how it's broken down. Yes, the vast majority, I mean, it's a bell curve. It is where it is the way that it's broken down. But you can definitely see in the images the increased density, which shows up white. Increased density carries 2 disadvantages to each patient. First of all, it masks that cancer on mammography. As I just mentioned, the increased whiteness that is seen on mammogram, the cancer shows up as white as well. So masking it makes the diagnosis less likely at a small stage.
So you can see that finding a tumor in this breast would be significantly more difficult in this breast. Dr. Schreck always likes to say it's like finding a snowflake in a blizzard, or a tree in a forest, or a grain of sand in the beach. Some of those breast cancers, as Dr. Deming can attest to, are very, very small when found. And that is our goal, is to help women make sure they're aware of their screening, and so we can find those cancers when they are just a grain of sand in the beach instead of a beach ball. So this fibroglandular tissue, a lot of the research now is also being geared toward finding out why this fibroglandular tissue also not only makes it more difficult to find the tumor, but possibly why those breasts have a higher tendency toward malignancy as well. If you look at how difficult this is in real time, obviously these are 2 different images because this breast is normal, it's fatty, you can see through it. And this is an MRI, the mammogram where the tumor appears, you can clearly see it. Now in a dense breast, these are both the same breast. very difficult to see that there's a tumor hiding in all of this white. But the MRI of that same breast makes that tumor very easy to find. So it's hard to tell how long this tumor was hiding in this breast before it was found.
So the second disadvantage to each patient is that it does increase the risk of getting breast cancer. As Dr. Paul mentioned, there's more and more research being done to find out, okay, so why is that increased amount of fibroglandular tissue where the breast cancer so often resides? So the women at the top half of that density, categories C and D, again, the heterogeneous and extremely dense tissue, they're more than twice as likely to be diagnosed with breast cancer than those at the bottom half of the density gradient. Women in the extreme category, so category D, are 4 to 6 times more likely to get breast cancer than those in the fatty category. So, and the extremely dense tissue breasts are second only to an inherited BRCA gene, BRCA gene, as an independent risk factor for breast cancer. It outweighs even a positive family history.
So the Iowa law, like I said, we're rather lucky. We're real inclusive. Every woman who has a mammogram is required to receive a letter that now must include her density. It may say fatty, it may say scattered, it may say heterogeneous, it may say extreme. You may also see A, B, C, or D. Fortunately, the Iowa Army of Pink is seeing a lot less ambiguity in those letters. At first, going back to the beginnings of 2018, we saw a lot of average density, no mention of density, several variations of the theme. And now I believe that everybody has been on board, and it was not Mercy's radiology department, by the way. They were always awesome, and they were always let us know. And it also states that if you are in the top half of the density, that this may obscure, small tumors and findings, and to be aware of your annual mammogram in a year, and that it may impair that early diagnosis. So we're really lucky here in Iowa. We have a very, very good law. Oops, did I miss one?
If we can go back.
Yes,
previous. Oh, there we go. So the good news is that it's not all bad news. So the flip side of all of that, talking about the top half, the more dense tissue, is the good news for those who are in the bottom half. Patients in the lower half of the density gradient, the fatty and scattered tissue, they're less likely to have cancer develop than the average woman. Moreover, breast cancer that does develop is very likely to be detected very early, simply with a mammogram. So that is, two very good news items. An interesting thought going forward would be, particularly with some of the different groups that advocate for every 2 years annually, these patients might be candidates for that follow-up. Of course, it's probably easiest to just stay on an every year, just because then you know your month, and every year in the month of my birthday, I'm getting a mammogram. But if there are candidates, it might be those at the lower end of the density gradient.
And women do not outgrow their need for mammograms either. Age is not an option to opt out, like a pap smear per se, where, at the age of 65, pap smears are not recommended anymore unless there's a problem. My aunt was 88 when her mammogram detected her breast cancer, and she had successful treatment and lived to be 90. 95 and died of a completely different issue. So every woman is different. Every woman needs to talk to their physician and decide their own risk and whether they're going to go annual or biannual. This was an interesting slide, and it was just an easy one to put together so that people could get a general idea of how many women in Iowa are affected by this law. And it's just a general slide with some averages. The population of Iowa, about 3 million, half of them being women. The median age in Iowa is 41 years old, which puts 750,000 women at the age of mammograms. 2/3 of them will get mammograms. 40% of them will be category C or heterogeneously dense, and 10% will be category D or extremely dense. That leaves us 250,000 Iowa women that need to know and be aware of their density. And as of 2018, this information may be very new to them. If they read their letters, a lot of women don't. Still to this day, they get their letter that it's normal, and they don't carry through and have these conversations with their physicians. And 250,000 women, that's a lot of us out there. So then we'll get the letter, and our goal is to get women to read their letters, and then obviously they'll have questions.
So with increased density, do we continue to get the mammograms? And the question or the answer is yes, absolutely. Because for one, the regular mammogram is where the most data is. And so those women with all density categories who maintain a regular mammogram schedule will live longer. That's our goal. And so we need to continue to have the mammograms. Even those in the extremely dense category, the most disadvantaged group as far as mammograms go, they will still often discover their own breast masks between normal mammograms. So they often do, but it'll still be 60% will be tipped off in the mammogram. So that's good. The type of mammogram should basically always be a 3D, especially with dense tissue. I don't even know, I think that many radiology groups are just going to straight 3D overall and not even having the 2D available. Medicare does pay for the 3D, which that is unusual to have Medicare out in front of some insurances. So, and that's been a few years ago. I don't even know if that's, you know.
That discrepancy is rapidly disappearing. I remember even just 3 years ago going in for my mammogram, they said, you want the 3D, you may need to pay out of pocket. And I'm like, it's what? It's going to get my nails done. It's going to pay a month of my cell phone bill. It's going to be, you know, going out for lunch today. I mean, yeah, I'll pay for the 3D. I have written 2 letters in the last 3 years for women to support getting a 3D mammogram, and both of those women had their extra copay or whatever they wanted to call it reimbursed back to them once I made the case for their 3D mammogram. So the equipment and insurance disparities are rapidly disappearing, and that's come from the public demand and the more awareness in the medical community of the importance of this.
So what other tests can be done on dense breasts to help detect the early cancer? This is a category called supplemental imaging. So again, mammograms are still the first line, and then supplementing those would be for patients who have who carry a 20% or more lifetime risk of breast cancer. Just even having the extremely dense tissue brings it very close to the 20% lifetime risk.
The automated whole breast ultrasound, for women now, when they have an abnormality on their mammogram, they'll usually get called back for a spot ultrasound for the area in question. The automated whole breast ultrasound is just what it states. It's the whole breast. There is not one, to my knowledge, in Des Moines. There is one in Ames, and that is where several of my patients have opted to go for their own peace of mind. It has a high incidence of false positives. So, that would require more studies, more biopsies. It's time consuming. There really is not a good statistical basis that it's finding any additional cancer diagnoses, and it is largely being phased out of favor due to a lot of those con issues. The MRI of the breast is the gold standard follow-up for an abnormal mammogram anymore. It sees through that density. It detects very small lesions. It's widely available. A whole MRI of the breast is very expensive. It requires IV contrast, which, I don't take lightly either. Many of my patients are claustrophobic. It also can have false positives. Now we're seeing more and more abbreviated MRIs of the breast. The slices are a little bigger, it's less expensive. And actually in Ames, women are able to go to McFarland Clinic, pay the money, and go without a doctor's order. I encourage women not to do that, just due to the IV contrast and the risk inherent in that. If they really feel they need a breast MRI, I usually refer them to the Katzman Breast Center for further evaluation. But that limited MRI is available to patients without a doctor's order. So there are several facilities in Iowa at this time, and so far I am not aware of any new ones other than those mentioned here in this slide. The molecular breast imaging is very expensive. They use a radioisotope, which also carries inherent risk. It is the most sensitive. It has the lowest incidence of false positives, but it involves a radioactive isotope. It has limited availability. You need to go to Mayo Clinic for that. And quite honestly, I don't know of anyone that's ever had an MBI. Do you?
I know of a couple that have gone up to Mayo
and had it done.
But that was 4 or 5 years ago that they did that.
Yeah.
Before the abbreviated MRIs came into being.
I think we kind of touched on this already. Insurance is still a major issue, but for different reasons. It's not so much the mammogram. Right now, we're seeing a trend in insurance companies not wanting to pay for the supplemental imaging because they feel they're diagnostic and not screening, which is not always true. You can still do a screen MRI to see if you have a diagnosis. So it gets semantical with some of these insurance companies. And I know that those issues are probably going to be brought to the legislature again real soon.
Yeah, I don't know if it will be happening this year, but hopefully in the near future we will get back in there. And
yeah, the Iowa Army of Pink is going to pick up that ball here really soon and decide where we're going to go with that legislation bill, because we'd really like to make sure that women who don't have the ability to have quote unquote good insurance are not being denied these supplemental imagings due to figuring out if it's diagnostic or screening in nature. But those with extremely dense breasts confer a 20% lifetime risk overall. And that in and of itself is usually an impetus for an insurance company to go ahead and pay. The last thing they want is to miss a cancer as well. So it's a balancing act right now, and it'll, hopefully, the strides we've made in the last 3 years are incredible. So hopefully in the next 3 to 4 years, we'll see even greater strides as we move forward with the breast density issue and the importance of early diagnosis and treatment.
So keeping the supplemental imaging, keeping perspective on that, again, it is supplemental. It's a fairly small fraction of women who are candidates. The extremely dense tissue breasts for sure, heterogeneous if they have additional risk factors. I was heterogeneous. I had heterogeneously dense tissue. My sister is the same. She is at risk above the 20%. I think her risk is 32%, simply because of my breast cancer. So her heterogeneous and the addition of a family history, bumped her over that. The main benefit of providing this density information comes from helping women understand what they're actually getting with mammograms. My impression had always been, oh, I got my mammogram, I'm good. They said it was all good. That's, it's like, black and white and they can see everything. And so helping women to understand what the benefits and the holes in a mammogram, and to make lifestyle changes. What can they do to help decrease their chances of breast cancer? And then the supplemental, again, it is as needed. It's not the what's going to drive women in to have that on an annual basis. So.
And as that last statement says, there's immeasurable value in bringing women into the conversation. And that is the role of the family doctor. And I think it's always really important to bring your patients into their plan of care. I sometimes am pretty hard-headed about some things that I feel are not negotiable on some treatment options, but for the most part, my patients are partners with me in deciding what they want to do. And breast health is no different than cardiovascular health. We go through what is changeable and what's not. I can't change that you're a man. I can't change that your dad had coronary artery disease. I can't change those things, but I can change the way you eat, and I can change the way you exercise, and I can help you mitigate those risk factors for coronary artery disease. And I would like to see the same thing happen with women in breast cancer. I can't change the fact that you have dense breasts. I can't change the fact that your mother had breast cancer, but I can, encourage you to get your mammograms and eat well and get your exercise and mitigate some of those other risk factors that are becoming more prominent, which leads us into body awareness. And I think that's very, very important. Breast exams, I believe, are necessary. If you ask a room full of women how many of them do their monthly breast exams, it's probably less than 30% on a regular basis. And I was one of those women. I was hit or miss. I was not aware that my breast density was making me at a higher risk, and I had never had a problem. And so I don't think that even as a physician, I was aware. So the lingo now is not monthly breast exams. The lingo is know your normal. Well, anyway, yeah. I don't know how you're supposed to know you're normal if you don't do your breast exams. So I encourage all my women to do their monthly breast exams. And of course, the lump or thickening in the breast, the bloody nipple discharge, skin dimpling, a change in texture. And once again, a recent normal mammogram is not reassurance. We all know people who said, I had a mammogram last month and now you're telling me I have cancer. Brigid is a perfect example, was having mammograms every 6 months and they were looking in the wrong breast. And she found her own. I know a woman who had a normal mammogram, but her tumor was over on the lateral side of her breast in her bra line, and it was not picked up on mammogram. we're going to hear all those stories. So we need women to get on board with, you need to be your own advocate. You need to speak with your doctor, and it takes both. It takes our patients willing to get on board to, do what they need to do, and then science and medicine needs to do what they need to do. So once a woman is identified, though, with high density, she should always maintain her annual mammogram schedule. Some of my patients who have been identified at a higher risk of greater than 20%, some of those women actually get an MRI, and then 6 months later a mammogram, then 6 months later an MRI, and they continue to do that through the rest of their life.
And then here is more of the information that we can change. We can make lifestyle changes. Obesity still weighs heavily into cancer, breast cancer being one of the areas. Inactivity, and this all goes pretty much hand in hand. Alcohol in excess of 1 drink a day. For some reason, especially white wine, most likely that would be because of the higher sugar levels in white wine versus red wine. And then, of course, reading every word, asking the pertinent questions of your primary care physician regarding your mammogram report, making sure that you are aware of all that is in that letter. What else?
Increased density, it'll influence our decisions. Women diagnosed with large breast cancer, are more likely to choose bilateral mastectomy. And those are all individual issues, and you cannot answer those questions for everybody. These are just things to think about. Brigid had a category 2B breast cancer. I had a category 2B breast cancer. She chose lumpectomy. I chose bilateral mastectomy. Every woman needs to make those decisions with their doctors and do what's right for them at the time. But the most basic thing women need to know is their risk, and that involves knowing their density. So we can't stress that enough. We do have additional resources. The Dense Breast Information Org has really, really good information. I haven't read it lately, but it's usually pretty up to date. And there is a resource on there for continuing medical education for doctors on that website. Then there's ours, the iowaarmyofpink.org. And a website that has come to our attention over the last 12 to 18 months is the IBIS Iconopedia, and it's an online risk evaluation tool. The TC model is got a patent and a, what's it called? You got to pay for it. I'm having chemo brain here, sorry. Not the trademark. Anyway, you have to buy the rights to use the actual Trier-Kurzik model. Some of the women will get their mammogram results, and some radiology departments are actually putting that score on their report, which is an incredible stride there. I think that's great. Personally, for me, my women who have had a mammogram all have an IBIS Iconopedia score on their chart. If I have addressed that with them, anybody who has a score greater than 20%, I immediately refer to the Katzman's Breast Center for further evaluation. I have had category B dense breasts with very, very high risk factors. I have sent to the cancer center, and I've also had extremely dense breast women who have no other risk factors. So, their risk is actually a little lower than 20%. So that's just another tool that I use in my practice to help women understand their risk. And then, of course, always call your doctor, call your radiology department, and that's about it. That's all for us. That's all we got.
Thank you. Thank you, Brigid and Dr. Paul. You know, you touched on several things, and obviously one of the big themes is risk. So every woman is at risk of breast cancer by virtue of the fact that she has breasts and more likely to develop breast cancer than men. And you touched on, obviously, the purpose of the talk was the risk of dense breasts and how that increases the risk of breast cancer. And you also touched on other things that increase the risk of breast cancer, including genetics and then some environmental factors. So for the most part, we think that you can't change your genetics, although I would bet 10, 15, 20 years from now, you know, as we start altering genes, that may not be true. We think that you can't really alter your breast density. But there are things that women can do to help reduce the risk of breast cancer. And you touched on some of them, but I maybe invite you to accentuate those things that every woman can do to help reduce the risk of breast cancer. So I'll let you guys start off. I've got some in my mind, but I'm sure you've got many in your mind as well.
Well, you know, like we talked about, you know, watching your weight, improving your diet. Sugar is very inflammatory. I think that is also becoming more and more prevalent in research, and bears out that, processed foods, sugar-laden foods, those all increase your risk of inflammation. So cutting back, doing a more Whole30 or, a cleaner diet, and exercise, obviously. Maintaining a healthy weight, but keeping active is very important for those who are trying to avoid cancer and for those of us who have already been diagnosed with cancer and are now survivors. Exercise is pivotal. Keeping active and just keeping living. It's a great thing. Exercise is. Goodness gracious, meditation, prayer, spiritually turning off life for a while, getting off your phones, getting off Facebook, communicating with your families, just being more spiritual and getting in tune with what your body feels like. And we are such a society that we rush and are busy, and I'm number one guilt. But if you're quiet and you're listening, your body will tell you all sorts of things. And it's pretty amazing when you sit back and listen, how you can heal so many of those little things just by being quiet. So.
Yeah. Brigid, any others to add?
I guess the thing that I just go back to repeatedly is, many times we can decrease our chance of getting cancer. But in addition, kind of side by side, is catching it early. And so it is getting the screenings that we need, staying on top of it, and realizing that that even these screenings are only as good as, following the instruction of the medical professionals. If it's an annual thing, get it annually. If it's every 5 years, get it every 5 years. Whatever it is, to follow up, it gives your body and your medical team the best chance to help you to survive it.
Yeah. And just to jump in, so you're right, risk reduction and then early detection. And so besides all of the things you'd mentioned, I never pass up an opportunity to say, don't smoke. Smoking and breast cancer aren't the most linked, but of all the things we can do to reduce the risk of any cancer, including breast cancer, is not smoking. And then I agree with everything you said, and that whole lifestyle, stress reduction. And we might call it meditation, we might call it prayer, we might call it community, but having this social connection does reduce the risk of breast cancer. And as you mentioned, maintaining a normal body weight, eating healthy, exercising. One thing that I'd put out there is that be aware, there's lots of clinics that pop up now that are willing to give men testosterone shots and women estrogen. There is a big risk of taking estrogen after menopause in increasing the risk of breast cancer. So estrogen after menopause has some health benefits, but it also has some risks. So that's something to consider. And then to just add on to what you said about early detection, huge thing to do. And some other tips is I think that women benefit by, as much as they can, sticking with the same imaging center, year after year, because although it's possible to get images from one center over to the other center, if you're getting screening mammograms, that's supposed to be done, but it doesn't always happen seamlessly. And one of the real benefits of doing annual mammograms is comparing this year's mammogram to last year's mammogram. So I think women who have a primary care doctor who's part of their health coach and who get their screening done and get their screening done consistently at the same location, probably you're more likely to detect an early abnormality than if every year you go somewhere else for your mammogram.
I agree, and I would say that's one of those things that I try to inform my friends and when I speak, is the fact that a radiologist is looking for just such minute changes, and so keeping it annual, keeping it the same imaging center is so important, because they then have the same software. Everything is relying on just such minute changes that it is very important to have as close to the annual time frame.
Yeah. Let me ask you guys a personal question. So you both have taken what Lance Armstrong used to call the obligation of the cured. You've used the wisdom that you've gained from your own personal cancer journey, not just to illuminate your own pathway, but to help others to help reduce the burden of cancer. And I know that the bill that passed the State House in 2017 would not have happened if it weren't for breast cancer survivors advocating. Maybe talk a little bit about what it means to you individually to use your own stories to help move the ball forward, to help pass legislation, to speak to legislators, and to be advocates.
Well, right away, I can envision myself sitting on the couch, looking at my husband, and when I got the phone call that said I had cancer, and I said, okay, well, this has landed in our lap, because we're partners in life. And I said, I don't know if it's for me or for somebody else, but I am not going to be one of those quiet cancer people, and I'm going to be telling people about it, and I'm going to be sharing what's going on in my life, because there are a lot of people who don't take breast cancer as serious as they should, and they just aren't aware of what can be done. And so right away, it was just that's also my personality. It's kind of like grab the ball and just run. And so it has been so beneficial to me as I went through treatment then to share the story and to help others, because it gave me a sense of why I had it. I'm surviving, thriving, and it just says, okay, and I'm not going to sit back and just take it. So.
And that's about the way I feel. I think it just goes back to the way I was raised and the way I've always approached things. My father was very influential in my life, and I remember one day he sat me down and said, sins of omission can be worse than sins of commission, and if you are given a gift, you're to use it. And I remember when he was diagnosed with breast cancer, he said, cancer is a gift if you use it correctly. Of course, I was young then and I was getting ready to lose my father. And he eventually did not die of lung cancer. He died of complications of the cancer, but I was still quite young and he left a big impression on me. I'm like, how in the hell can anybody think that cancer is a gift? But I had a year to spend with him after his stroke, and he taught me how to live without him. And so here I was given this gift, and what am I going to do with this gift? I would not have met Brigid. I probably wouldn't know Dr. Deming as well as I do. I wouldn't have met a plethora of people that are now near and dear to my heart. I wouldn't have been able to talk to that patient and say, yeah, I'm thinking you should go get that mammogram, you know, and have them come back and go, you saved my life. If you hadn't encouraged me to go, I wouldn't have known I had breast cancer. So for me not to do what I'm doing would, for me, be a sin of omission. I wouldn't be using that gift of cancer to give back. And that's the way I've always looked at it. So it's just what I need to do.
Mhm. Can't hear you.
Hey, Dr. Deming, I think you're muted.
Thank you. You know, you'd think we'd figure this out. Sorry about that. My first time on a Zoom meeting. I know. So thank you. Thank you so much, both Brigid and Jean, for, you know, sharing your own personal story, because, you know, people go through their cancer. Everyone does it differently, but for you to be able to share your story to make a difference in the lives of others is just really heroic, and you inspire me. And it's because of individuals like you that we're able to pass legislation like the breast density law, and we're able to help advocate for better public health policy that will reduce the burden of cancer for everyone. So thank you for being here this evening, and I'm going to turn it over to Chris to wrap it up for the evening.
Thank you
Yeah.
so much for this opportunity.
Thank you.
Well, it was wonderfully done and quite informative, for sure. And the one key element is the people part of, you both ran into Brigid Polkowski, and Dick and I know her well. She was on our trip to Colorado, she and her husband, and it's the power of people. So you guys are out there, as Dick said, doing, communicating and telling people what they need to know. And if other people want to get involved in the Iowa Pink Army, can they do that through your website, or is that probably the best path to take?
They can do that. Contact us. Iowa Army of Pink at Gmail is the general email, and we hope to be at the Iowa State Fair again in August.
And we will be needing volunteers to help man that. So yeah, we'll take anybody who wants to come out and help us spread the word.
And they will be trained.
Yeah.
Yeah, that's good. We'll hope to all be back at the Iowa State Fair in August. So thanks everybody for joining us this evening. And this will be, it's obviously been recorded and will be on our YouTube channel. And our YouTube channel at Above and Beyond Cancer has all of these cancer education series, which are brought to you in part by a grant that we received from the Iowa Cancer Consortium. So thanks everybody for joining us, and thank you too for being part of our cancer education series this evening. We'll look forward to seeing everybody again next week.